Good evening to everyone, and welcome to the Clinical Associate Student Webinar. So my name is Aviwe Mkobozi, and I'm the head of the Division of Clinical Associates, and I will be your host for this fantastic and amazing hour. I'm really excited to be hosting our special guests, and I will introduce them to you in a moment. So these webinars we have on a month-to-month basis, and they're commonly for students where we invite clinical associate graduates, and they come and they speak to the students just about the different workplaces. They speak about the experiences, and we link them together so that students are able to be informed, to be educated about the profession, and they get an opportunity to ask questions. But for today, we've got a mid-year special, which is going to run a little differently. We've got the special with industry leaders, with pioneers who are going to be speaking to the students about the clinical associate profession. So the theme for today is going to focus on the clinical associate role, the impact, and the value, which is really, really quite important. And a lot of people do ask questions about it. A lot of people have identified it already in their spaces, but we just want to set aside the hour to talk about the role, the impact, and the value of the clinical associate. So, of the guest speakers that I'm going to introduce to you, they will be talking and touching on one of those elements, or all of those elements that we are focusing on today. The first thing that we are going to do is to have an opening statement from each of the guests, and I'll ask for an opening statement which relates to one of those topics, which is either the role, the impact, or perhaps the value. And each of our guests have got a particular concept that they're going to touch on. So the first guest, in no particular order, but I'm going to start with Dr. Ngobo, Sanele Ngobo. Sanela was among the first group of clinical associates to graduate at University of Pretoria in 2011. He was then seconded by KwaZulu-Natal Department of Health to work for University of Pretoria as a junior lecturer for the clinical associate students in 2012. He is a clinical associate. He's got experience in research and teaching students within the medical field. He then worked with community health workers and with developing electronic applications for them. He completed his PhD, which focuses on evaluating the role of ward-based outreach teams on supporting patients living with HIV. So I'd like to welcome you, Sanele. It's great to have you. Someone who's really pioneered and is still pioneering forward. So please may you provide us with an opening statement.
Good evening, everyone. No, thanks, colleagues, for the opportunity just to come and join the colleagues in terms of sharing some insights on the value of clinical associates. Of course, this journey started quite some time, years back, and we're so happy that today we're here. So there is quite a very important and a critical role that can be played by clinical associate in our healthcare system. As you all are aware, our health system is in need of more healthcare workers. We need more hands. We need more highly trained healthcare workers. And we as clinical associates are the solution to the current crisis in terms of clinical associate. But maybe just to align it with what is happening currently in the country, I think there's a shift towards universal health coverage. And if we want to achieve universal health coverage, one of the things that we need to look at, and by universal health coverage, I mean NHI. So if you want to be able to achieve universal health coverage, I think it is critical for you to strengthen your healthcare workforce. And as clinical associates, we come in there. That's where we come in and have a critical role to play in terms of strengthening our healthcare system. And that cuts across the board. So they're starting from the lower levels of healthcare, from the community side to clinics, to CHCs, to district hospitals, even to higher levels of healthcare. When the profession was started, I think we were aiming mostly to contribute in the district hospital level. But I think our vision has now expanded because there are more opportunities coming across, including the other levels of healthcare, like I've already mentioned. But there's also an opportunity coming up now, especially with the national health insurance coming up with an aim of achieving universal health coverage. And I think that is one of the critical areas where maybe we need to possibly look and say, what contribution can we make? And I think this comes with a great opportunity because not only are there going to be opportunities in the public sector, but also in the private sector. Looking at the nature of the training of clinical associates and the nature of the challenges faced by the public health system, I think there are more and more opportunities coming up in the private sector, which we should utilize. Of course, some of us who are mainly concerned about the public sector would appreciate that more clinical associates be there in practice in the public in the public sector, but due to challenges, I think we are seeing more and more opportunities availing themselves in the private sector, because I think there is a very strong appreciation of clinical associates in the private sector as we continue going forward. Of course, this does not mean that we must abandon our original mission, which was to strengthen the public health system. So I think among things that we as a profession should be thinking carefully about is how do we contribute towards giving our nation better and quality healthcare services? And that we can drive that through availing ourselves in across all different levels of healthcare. Maybe last thing, before I stop, is to mention that one of the things that our country has tried to achieve, and they've tried to achieve this by sending students to Cuba, medical students to Cuba, so that they can come back to South Africa to improve the preventative component of medicine, which we haven't been able to achieve. And I think as clinical associate, that is one of the possible areas where maybe we need to be focusing on and saying, as clinical associate, we could be a solution to our current hospice-centric health system, which focuses on treating those who are sick. We should be driving the agenda of preventative medicine and pioneering and encouraging our health system and our people in the country to move towards more preventative healthcare system. Thank you.
Great. Thank you so much. Thank you so much, Dr. Ngobo. So much was said in that opening statement, but we're going to unpack it in the panel discussion. Thank you so much for those thoughts. I'm going to introduce the second guest speaker, Ms. Zuki Chabalala. So Ms. Zuki Chabalala is a US trained physician assistant. She received her bachelor's in biology from the University of Georgia, thereafter working as a medical assistant for a group of pulmonologists. Zuki went on to complete her Master of Medical Sciences at Emory University, becoming a certified physician assistant. So in 2004, around that aspect, around that time, she came back to South Africa and she started working on getting a national and university level approval for the introduction of clinical associates or similar profession within the South African healthcare system. So Zuki began working with the University of Witwatersrand and assistant in the development of the clinical associate curriculum there. She was really instrumental in getting this curriculum approved by the faculty board. And since then, she joined the University of Pretoria, and she's currently the head of the clinical associate program there. So welcome, Zuki. May we please have your opening statement?
Good evening, everybody. Thanks, Aviwe. So mine is just to give you a little bit of a background about how this profession came to be in South Africa. And it really is in response to anybody that is a post-apartheid person. We do know that one of the visions of the South African government, even the current South African government, is to make sure that everybody has got adequate access to healthcare. And in response to that, there was obviously a need for another cadre of healthcare providers. There were just not enough doctors to go around. There were just not enough nurses to go around. And As a matter of fact, there was actually a study done in South Africa to see where we were with respect to the delivery of healthcare in South Africa and what it would mean for us to be able to provide primary healthcare to everybody. And the recommendation was that there should be another healthcare cadre in South Africa. And that was actually the beginning of how this particular profession grew in South Africa. However, what initially happened was we were not sure what that meant. What would that cadre do? So another research was done to find out where this cadre would fit within the healthcare system. And in discussing how this would happen, we actually looked at different professions that were similar on the African continent, and then we also went global. So we looked at the physician assistant in the United States at the time specifically, and then we looked at the various flavors of this particular cadre within the African continent. And after looking at all of that, we came on the fact that we should actually provide somebody that is a primary healthcare provider to the who would work specifically within the district healthcare setting in South Africa. Obviously, the profession has actually morphed a little bit now, but it was also in response to the fact that at the time, there was a huge exodus out of South Africa of doctors, of professional doctors, experienced doctors. They were actually leaving the country. So there really was a need. And even now, if we were to look at, our ratios of healthcare providers to people that need healthcare or the users of healthcare, we're still not at the right level. So it was in response to that. There's a lot of literature that was done. We then asked universities which universities would really be willing to go ahead and provide this. And Walter Sisulu University, WITS, and UP stood up and said that we would be able to do it. And as Avio has alluded to, I was very instrumental in some of the development of some of the curricula and the content therein. So that's all. That's where I'm going to stop for now, Avio. It's just for us to explore what does it mean to ensure that we give, good quality primary healthcare to all that need it in our country.
Thank you. Thank you so much. Thank you so much, Zuki. We shall unpack it. So our third but not least guest speaker is Mr. Scott Smalley. He is a registered clinical associate in South Africa and physician associate in the United States. He completed a Master of Science in Physician Assistant Studies at Northeastern University in Boston, Massachusetts. Pronunciation. He's the president of the International Academy of Physician Associate Educators, and he was the prior head of division of clinical associates here at University of Witwatersrand. So following the 5-year term, he played a huge role during the COVID times with the vaccination project at WITS. And following that, he was granted the 12 months of sabbatical where he could actually research on the global footprint and just the spread and the growth of the profession in other African countries. He is the chair of the National Clinical Associate Consortium that involves stakeholders to mobilize the clinical associate agenda in South Africa. So his research involves the global PA analog footprint for assessing education, curriculum mapping, and competency outcomes leading to clinical practice. So we welcome you as well, Scott. Please provide an opening statement.
Good evening, and thank you, Viwe, for that nice welcome. And hello to everyone on the call. It's great to see we have 80 persons on this webinar tonight. I'm so very excited about that. So through my travels last year, the year before, I went through 10 different countries of Africa and traveled through much of the United States, and previously had been to 20 other different countries around the world that have our clinical practitioner. There are 68 countries around the world that train, educate, and employ clinical practitioners such as ourselves, and we have 35 different unique titles. Clinical associates is not alone. Also in Malawi, they call themselves clinical associates. Much of East Africa is called clinical officer. And you may know in West Africa, they're called physician assistants. And across the pond over in the UK, the physician associate. In the United States, had the name physician assistant and just changed recently to physician associate. And over in Malaysia, they are called medical assistants. And I was fortunate to be there for a conference 2 years ago, and I met many of our colleagues there. And Malaysia is actually one of the first countries to have started this training program for clinical associates. They started in 1794, and they had 2 medical assistants who came over from India, and then Malaysia started their training. So even before Malaysia was India, with what were called dressers or hospital assistants. We have a very long time old profession here. In Africa, we started in 1897 in Uganda. They were training at the hospitals there. And then Kenya started in 1929. Kenya now has one of the most robust clinical officer training programs. Do you know 80% of the medicine in Kenya is performed by clinical officers? There are 28,000 clinical officers in Kenya, and there are 12,000 doctors. So majority of those healthcare providers are, like us, clinical officers there. But really, the original prototype of our profession can be traced back into the early days of what was Russia then, and Peter the Great, and the armies that were rolling across the country there. And many people were getting injured, of course, in the battlefields. So they needed a medic, they needed a clinical officer or clinical associate to take care of the soldiers. And so they called them Feldsheers, Feld being field, and shears being the cut or the cutter. You may know the term the early barber surgeon. Barbers who cut the hair and shave were very good with the knife, so they were often used to do amputations or wound practice. And so these persons, these surgeon barbers out in the field, were called field shears. And there still are Feldsheers in Russia and in Europe that are practicing just like us as clinical officers, clinical associates. So really what I wanted to share is that we are a global community of healthcare providers around the world in 68 countries. There's estimated to be more than 1 million clinical practitioners around the world. We are not alone here. Even though we started in 2008, there are many programs that also started. 2004, Germany started, and 2003 is when the United Kingdom started, and even just recently in 2012 is Rwanda started, and our neighbors in Botswana started in 2015 with what they call doctor assistants. So thank you, Viwe, for just a bit of a global context, and looking forward to the conversation of how we can discuss really the value add that clinical associates bring to South Africa and around the world.
Thank you. Thank you so much, Scott. So if our viewers and attendees realize, they'll see that each of the guest speakers have got a particular, they came from a different perspective, right? So Ms. Zuki Chabalala spoke about the background of clinical associates. We had Scott who spoke about the wider, almost continental perspective of the profession. And we had Sanele speaking about just shaping policy. So we're now going to unpack that and go into depth into the various concepts. And I'll start with Zuki, just for us to explore the role of the clinical associate first. So we'll speak about the role, we'll speak about the impact, we'll speak about the value. But just in talking about the role of the clinical associate, what was the rationale, if you can expand on it, you spoke about it, of introducing this profession?
So actually, one of the things that they did, and I don't know how many people really know this, is they approached the nurses specifically. And one of the things that they got from the nurses was that at the time, there were a lot of nurses that were doing things that were way beyond their scope. So that was almost like a point of departure for us to say, okay, then let's see what are the things that you're doing right now that are beyond your scope. And then, there was there's this whole concept of where will they fit in? Are they going to be in the primary healthcare, in the clinics with the primary healthcare nurses? That then creates sort of a gray area around, well, what is their role going to be? But then there was also, remember, an issue of space. We're talking about where then would they consult? And at the time, there was also a need for family medicine practitioners to actually do more outreach. And so the idea was that if we want family medicine practitioners, our family medicine specialists, to go out in the outreach, we still needed to have healthcare providers to provide healthcare in the hospitals themselves. So the initial training, for those of you that remember that are early students of this program, a lot of the training was centered around going to district hospitals, because the idea was that that is what the clinical associate would do. And then for some of the specialities, specifically with ops and gynae and mental health, the idea is, instead of it being very broad, we would actually really look at emergencies. So what are the obstetric emergencies that we should train clinical associates in? What are the mental health emergencies that we should train clinical associates in? So the initial thing really was, let's make somebody, for lack of a better word, a hospitalist. So they would be able to run the emergency departments in district hospitals. They'd be able to do all of the ward work in the district hospitals, and it would free the family physicians to go out, because they really were needed to support the nurses in the primary healthcare centers, also in the community health centers. They really needed the support at that time. And at that time, there were not that many family physicians even to begin with. So you can imagine what the need was. And if the idea was that we were supposed to strengthen primary healthcare, we really needed to have kind of like an overview. And obviously, as we'll talk over the course of this hour, that role really morphed. But I think it's important for us to understand that really the training is still grounded in that idea of supporting family physicians, so that we can actually reach out to more people that need healthcare, those that can't even make it to the hospitals. And so if we look at what district medicine looks like, it actually, we become more complementary in that we can support the hospitalists, we can support people out in the communities as well.
Thank you. Thanks, Zuki. And then I want to also elaborate on the specific tasks. So you speak about that there was that gap in terms of the skill set between the doctor and the nurse. What was envisioned for us in terms of how are we going to be trained, and what are these specific skills that was envisioned for the kids?
So actually what we did was we also looked at what the family physician skills are. Remember, there's the run-of-the-mill doing a consultation, but there was also there was really a huge need for somebody who would be able to do skilled clinical procedures. And I think especially with the UP program, there's this big thing where they used to be called procedure bunnies. And that's actually where that comes from, is that, at the time, the nurses really were doing procedures that were just not in their scope, because there was nobody else to do them. And therefore their work suffered. So they were not able to do what they were supposed to do. So we needed to fill that gap. But our argument was that we didn't just want somebody that was skilled. We actually needed somebody that was going to be able to consult, going to be able to counsel, so that they were more of a well-rounded person. And therefore the idea was then they could support the family physicians a lot more. But there was also, I don't want to take away from that emphasis of a very strong, emphasis on procedures, skilled procedures. So there was a whole list that was formulated. What could the clinical associate do? Some of the things actually that were on the list were ultimately thrown out because it was felt that they were too specialized. If we talk, especially the specialists, they're the ones that gave us feedback and said, no, this is a bit inappropriate. And that's why we then went and said, okay, what do the family physicians feel that they are able to do and therefore can supervise a clinical associate in doing? And that's how we came out with sort of our baseline list. However, I must say the idea with clinical associates has always been that if they get trained in any sort of procedure and they become competent in doing it, they ought to be able to do it with the view that whoever is supervising them is also competent in doing it. So they can't do something that, if say they work for a GP who doesn't do cesareans, they can't now start doing cesareans, if you understand what I'm trying to say. So it's always about working with a qualified supervising doctor. And by the way, I'm using the word with very specifically, as opposed to using the word working under, because it is supposed to be a collaborative and a team effort. And those were always some of the underpinnings, the things that we really did try to emphasize when we were rolling this out to begin with, when we talked to, other doctors, when we talked to other professions, as we're starting to get this profession going.
Great. Thank you so much, Zuki. Let's move on to then Scott. And I want to now move on to the impact. So once we've established why the profession was conceptualized, we can see the reasons. Then let's move to now impact locally, but also impact globally. And my question to Scott is, how do clinical associates impact patient care and outcomes? But also, how do they contribute to the efficiency of healthcare from what you've seen traveling the different countries?
Yeah, thank you, Viwe. Really, there's three areas that we have a strong impact on. It's really the patient numbers that we're able to treat and see and support, and it's really helping to alleviate healthcare shortages that exist, around the world, and particularly here in South Africa. And in that, enhancing the clinical teams that are active. We know so much of healthcare is moving towards teams, and it's not done by one person alone. But if I start with the patient numbers, I mean, we estimate there are 1 million clinical practitioners around the world, and if they each see 20 patients a day, that means today 20 million patients are being seen by clinical associates. And just here in South Africa, we have 1,400 registered clinical associates with the Health Professions Council. And if they treat 20 patients a day, which we know is kind of a low number, then we're seeing today 28,000 South Africans are treated by clinical associates. I mean, that's a significant number that happens every day. That's in a year, that'll be 10 million patients, 10 million patient visits provided by clinical associates throughout South Africa. And really, South Africans, we are adding to the healthcare shortage crisis that's happening here. We don't have enough of the doctors, we don't have enough nurses, we don't have enough other healthcare providers, but clinical associates can come in with a 3-year training and trained for the common conditions of South Africa. There was a top 100 medical conditions list that was created in 2005 through a study of the different district hospitals. And these top 100 conditions are really forming, the basis of the clinical associate curriculums. And certainly the top 20 conditions are what clinical associates are really well trained to take care of. And so these graduates now are filling these teams throughout South Africa and filling what is the healthcare shortage. Estimated in Africa to have 6.1 million healthcare shortage by the year 2030. And so we really need to do our part in South Africa by training very capable South African clinical associate students who graduate from matric and are very interested in medicine and can make a difference and come into this 3-year training program, can graduate and have employment at the clinical level, at the district hospital level, at the tertiary hospital level, and really make a difference, moving into the public sector, private sector, NGO space, research space, and even becoming academics, to teach the future clinical associates. Through my travels, I just see a lot of what's happening is that clinical associates are involved in task shifting and task sharing. And that's really the model that's taking place, particularly in Africa, is in Ethiopia. We have the emergency surgical officer who is like a clinical associate. They've been trained up to take care of maternal care. And they have effectively lowered maternal mortality that's happened in Ethiopia because they're trained to do cesarean sections. They're trained to do laparoscopic procedures for helping women in issues of pre or post-pregnancy. They've really made a difference there. And just to the north in Zimbabwe, they've taken nurses who are midwife nurses and trained them up in a 2-year program to be a clinical officer. And they've shifted the tasks of what would be the obstetrician role to share it with these clinical officers, and really also making a tremendous impact on lowering maternal deaths. So it's just a few examples that are happening throughout, here in South Africa and throughout Africa with shifting of the tasks where very capable clinicians, such as a clinical associate, can take on, the common conditions and can be trained up underneath supervision and through further training and experience, take on other medical conditions that are relevant for us in South Africa that need treatment. Thank you, Viwe.
That's great. Thank you so much, Scott. And I like how, impact is very difficult to measure, but I think once you look at patient outcomes, then you can verify and say, look, having clinical associates and having the profession globally, there's actually impact on a day-to-day basis. Thank you so much. Any inputs from Zuki?
Yeah, sorry, I'm dying to add this input because I'm sure Sanele can't toot his own horn. I think the one thing sort of that stood out for me that made me say, yeah, we're actually doing the right thing is that, remember one of the things that I talked about was this idea of skilled procedures. So Sanele actually did a research where he looked at VMMC and how do clinical associates actually fare in comparison to general practitioners or other doctors that do it. And actually our numbers came out much better than that. And the reason for that is that the clinical associate, again, it's just the way that the training is. There's not a lot of extraneous stuff in the curriculum. It's very focused. In Tshwane district, and when we talk about roles, we've really started making inroads with respect to the fact that, substance abuse programs are run by clinical associates in Tshwane district. Street medicine is a big thing now, and that is also run by clinical associates in the Tshwane district. And it's actually making a positive impact. Remember during the COVID times, and they had to put, especially the homeless people had to be put into contained areas. Those areas were actually run by clinical associates, with, family medicine registrars. And I think it speaks a lot to, the chameleon nature of the clinical associate, for lack of a better word, in that they can change, they're very adept. And I think part of it has to do with the way that the curriculum is set up. It allows for them to be able to, pick up different roles depending upon where it is that they're needed. So I just wanted to add that little point there.
Thank you. And I'll ask a question back to you, Zuki and Scott. Is this being captured? Where are we? There's certain people who can see what's happening around us, but what's needed for the impact to be captured and almost seen in a widespread manner?
Yeah, I think we're getting better. I think initially we were so focused on sort of just the academics of getting people graduated and making sure that they were safe practitioners. But I think we've gotten to the space now where we can actually do proper research and have good numbers, because those numbers not only talk to the impact of what the clinical associate is, but I think it also informs the curriculum. So it allows us to make sure that we're making the appropriate adjustments and that we're not putting out a product out there that is not necessarily fit for purpose. So, researching does have a twofold purpose. And I think within our universities, we're also being very intentional in making sure that we're hiring people that will be able to assist in doing the research, because that research is going to have to come from our departments, at least as a start. Yeah, you have some people that are doing it that are not necessarily within our departments, but we are the ones that need to make sure that we're actually putting out more of the research. And that again speaks to another role of the clinical associate. We are getting into that research space as well.
True. Great. Thank you.
Viewer, I can share that just you asked a question about research, and what Zuki was saying is there was so much attention in the beginning. I mean, all of us have been educators and involved in that development of the curriculum. And of course, we worked very closely, the three universities together, in developing the National Clinical Associate Academic team, which really helped to solidify what was the important exit outcomes and what was the important competencies our students needed. And I think it's really one of the strengths of this program is that we provide a strong education in the foundation of medicine and in general medical practice and the common conditions. And then students, when they graduate, can go on to advanced training in areas. Of course, WITS has the postgraduate honors, the honors program in emergency medicine. And I know UP is developing program, Sulu. There are other universities that have postgraduate diploma programs for clinical associates to gain those extra skills. And if they work with a specialist in an area and consultant, they can also gain those skills, and they can provide that as practice. I mean, one of another strengths we have is our scope of practice, which says that a clinical associate can perform any medical act delegated to them by their supervising medical practitioner in line with their education, training, and experience. Education during their 3 years, their experience that they gain when they're on the job, and they can really move into all these areas of medicine where they're needed, provide treatment for South Africans. Coming back to that area of research is, recently Sanelli and a team has put out a systematic review where they're looking at all of the articles that have been published around clinical associates. And to date, there are 36 really important articles and studies that have been done, ranging from their impact, ranging from their cost effectiveness, ranging from their areas of education that they can go into. One of these studies that he looked at was by Setapelelo, and it was 2022. It looked at 45 clinical supervisors and asked them how do they see clinical associates making an impact in the common conditions in their district hospitals. And 96% of them all agreed that clinical associates provided impact to HIV and opportunistic infections. And 96% agreed they provided impact on communicable diseases. 95% said they all provided impact on tuberculosis. 91% all agreed they provided impact on injury and trauma. And so just reading off this list of many, many areas where clinical associates are making impact, and studies and research is really showing that.
That's great. Thank you so much. Thank you, Scott. And we need more, because really the data needs to be collected. And there's a lot that clinical associates are doing in various spaces. I'm going to ask Sanile next. He will be speaking more about the value. So my question really to Sanile is about, how do we ensure that there is quality in the healthcare that clinical associates are providing, and how are clinical associates helping to address the human resources for health shortage? Because when we start to speak about clinical associates, we always talk about there is a shortage of healthcare workers.
Yeah.
But if you're going to talk about the value, how are they assisting in these gaps?
Yeah, thanks, Avi. Maybe let me just start from the issues, just for general public. So, as you know, in South Africa, we are struggling when it comes to the socio-economic issues. So one of the things that the profession obviously contributes with is that, at least when it started, it focused mostly on the disadvantage in terms of the recruitment and giving them opportunities. So one thing that it does address is that it gives skills to young South Africans who would have had opportunities to get such skills. And I think that is quite very critical contribution into our South African population in general. But we are also having some other issues. And in terms of quality, like we have mentioned quality, this is a very important aspect of it. And it also starts from selection. So when we're selecting, we just need to ensure that we're selecting right candidates from the right place, and who are passionate about joining the profession and who want to be here, so that we don't end up with people who are here, but just for the sake of it. So that by the way, can also have an impact in terms of the output and the quality of work that is being provided by a clinical associate, because he wants to be here. We're not going around begging him to say, please stay within the profession. So he's here. But also in terms of the program, I think there is a need to have very strong theoretical and practical background of the training at a high level, and assess clinical associates even as students at a level that would assure us that as soon as they go out there to represent the profession by practicing in the health sector, whether it is in the public or in the private, they are true representative of us as those who have trained them, because they are able to provide quality. So as we train them, we must ensure that they are the reflection of what we would have taught them. And so the undergraduate training plays quite a critical role and component in terms of quality. But we also look at the issue of supervision, and this is one of the important issues. And I know that there have been debates, and I think I support quite various kinds of debate. But we need to look at the supervision that is available to clinical associates, both at an undergraduate level, when they are being trained, when we are exposing them to clinical settings. Are we supervising them enough? Are we giving them enough exposure? Are we there to work with them and to take them through? That contribute to quality. But also after they've graduated, a clinical associate who have just recently graduated, it's difficult to expect them to function at a level of someone who has practiced for 5 years or for more than 5 years. So we need to ensure that there is stronger level of supervision for younger clinical associates, in particular who have practiced for less than 5 years. We protect the profession by ensuring that they are adequately supervised. But also we have guidelines, clinical guidelines, which are guiding practices. And I think we need to ensure that as they practice, in fact, from an undergraduate level, we need to ensure that we get into this habit that these clinical guidelines are made by specialists in different departments who understand and who have set a standard to say, if you are treating a patient with these conditions, these are these particular steps that you need to be following. So that plays a critical role in terms of ensuring the quality. But also we have ethical guidelines, which are coming from the HPCSA. Those ethical guidelines assist us to adhere in terms of in our interaction with patients, in the way we conduct ourselves. They are critical in us coming up with quality work. But as soon as we graduate from an undergraduate program, it doesn't end there. We don't throw our books away and say, now I'm a graduate. Now I can just, it doesn't end there. We need to ensure that, and unfortunately, and maybe let me just use this opportunity. Currently, in South Africa, only 9% of clinical associates are compliant when it comes to CPD points. So every clinical associate who's practicing, they need to get 30 CPD points every year. Currently, only 9% are compliant. And for doctors, I think it is around 25%. So we need to be saying that as long as we are not interacting, in fact, sometimes we do interact, but you don't adhere to the guidelines, which says that once you are interacting, ensure that whatever system that you are interacting with, or whatever lectures that you are interacting with, let them be accredited by the HPCSA so that we can be compliant. So that also contributes, because if a profession is seen not to be compliant, I think it creates a negative impression from some of those, and this is a profession which is a target of some people who might not like the profession. So anytime when there's something that was seen as if we're not adhering to, then it's an opportunity for people to crash it down and say, look, we told you, we warned you about this profession. So we should be shying away from such practices, ensure that we adhere to all guidelines. But also, maybe lastly, I think I'm just going to touch, in the interest of time, I'm just going to just end with the issue of postgraduate qualification. It shouldn't end also with you getting your undergraduate degree. I think we are trying to push as much as we can to avail opportunities for clinical associates to get into postgraduate qualifications. Just recently at the University of Pretoria, we have had a good opportunity for those who are graduates, who are clinical associates, who have just recently graduated, who are unemployed. 85 of them now, they have opportunity to study a PGD in public health, postgraduate diploma in public health, and they are going to be fully funded by HWC. So these are types of activities that we need to be engaging on, to say that we need to empower clinical associates with more knowledge, with skills, so that as they go out there and they work, you can point from a distance that is a clinical associate. Thank you.
100%. Thank you. So, wow, there's so much information, and we touched on the role, the impact, and the value. So, for the next 5 minutes, that we can get a Q&A session running, then where to from here? What is the future looking like? How do we want to maybe form the identity of the clinical associate? Is it almost organically forming by itself into these different areas that we didn't see coming? The clinical associates are now going more into the private space, whereas initially they were conceptualized for, I suppose, the public sector, but we're seeing that they're infiltrating all these different spaces. So where to from here, and what is the future looking like from the panelists?
I think I'm going to start. I
Okay.
think, it's so easy for us to say, oh, government, government, government. I think it's really easy for us to say that. I think that I still don't believe that the government, which backed and actually this is their concept, is really doing what they're supposed to do. Part of it, and I'm going to defend them on the one hand, part of it is just institutional memory. People leave and they don't, and then new people come in and they don't understand the concept of it. I think maybe the first thing that one needs to do is, rather than trying to do this thing on a national level, I think maybe we need to talk to provinces, because at the end of the day, they then have to create budgets. It still creates a little bit of angst in me, because we have not saturated the need in the public sector. And as much as, I'm fine with the fact that, people do need to eat, and therefore if the opportunity is in the private sector, then they must indeed go there. But that's not what we need in South Africa. Whether or not, and I hope Sanele speaks a little bit to this, whether or not, the fact that now the president has signed the NHI bill, and then that ultimately rolls over, what is our role there? How do the clinical associates ensure that they do have a positive impact and continue to do that? Because I think that could be a great starting point. I do want to quickly say, one of the things that Sanele was talking about was sort of the postgraduate thing. I talked to a urologist just this past weekend, and there is a need, for more hands within that space of urology in the public sector. if you look at cancer and how we screen for cancer and how we manage cancer and how many oncologists we have, it is absolutely unacceptable that you still have people that are waiting so long in order for them to be managed. And it's not because there's no equipment, it's because there's no human resources to see these people. So I think we are not there yet. Forget about clinical associates, just South Africa and its ability to provide for its people with respect to healthcare. We're not not yet there. I think clinical associates are not utilized to their maximum yet. So the what next is, and I don't have an answer to that, is how do we ensure that we are maximizing the use of clinical associates? Because I think all of us that are educators believe in the product that we're putting out there. So that's not the issue. The issue is what next. Policies have to change, and those policies need to be properly implemented.
Thank you. Thank you so much, Zuki. You highlight such important points about also access to healthcare. Access to healthcare is not only necessarily, I suppose, within a problem within the public sector. You now bringing up an issue in the private sector to say, even then, we actually don't have enough specialists. So there is a space and a niche where clinical associates can be in that space and render services. Complementary or yes, as supervised by the specialist. So it's a very important point, and I'm seeing a shift or a trend where a lot of specialists they're contacting us, whether it's a pediatrician, it's a cardiologist, and they would like to work with clinical associates.
I think what is also important is the voices of clinical associates in different aspects. I think wherever clinical associates are, starting from undergraduates, from students, from graduate clinical associates, I think we need to be educating our communities and our people, and in different levels. I think we need now to move, because now we used to say that this is a new profession, but yeah, is it still new after almost 14 years now? So we need to ensure that we are still able to drive this particular agenda and make it our responsibility that all of us, wherever we are, we become advocates of this profession. It cannot be done by one organization or by one university. It needs collective effort. I think such platforms are quite very critical, and we need to be advertising this profession in schools, in any platform, social media platform. When I see students posting and wearing scrubs, but they don't mention that they're clinical associate, I say this is a missed opportunity to educate people that we are having clinical associate, because the issue of having our people, in particularly when we have a clinical associate, a good clinical associate who treats patients, and then patients then write a compliment to say, Dr. So-and-so treated me very well. It's a lost opportunity, because they would have said a clinical associate treated me. Then people will start asking, okay, so who are these clinical associates? So that's a missed opportunity. So I think going forward, and once you do that, once you start from the ground and have a very strong base, which is supported by the people who have a clear and a strong understanding of clinical associates, then you can never go wrong, because by the time you reach government, already the masses are talking. They're saying, we need that profession.
Sanele, don't run away. I like the aspect that the credit must go to where it's due. Absolutely, the credit must go. It mustn't be misplaced, because that's not then truthful. It's the clinical associate who did that, and they did a good job for the patient. But I wanted to ask about the NHI. Just a few thoughts. Zuki alluded to it. Your thoughts about clinical associates and the NHI.
So what the NHI is doing is that it's opening up the health system. It's creating many opportunities. Of course, there are negative points and there are differing views on it. But I think one good thing about it is that it's expanding the healthcare system. It's making it as wide as possible, both in the private and in the public sector. So how then do we focus? How do we prepare ourselves? I think we need to be looking more towards partnering with general practitioners in private healthcare. And I think this way now of partnering is quite very important, so that we are not just seen as those who are just doing locums or those who are just come air. We are permanent part of the solution. So we partner with doctors who are having private healthcare. So if there's a small area where you are coming from, and there's a clinic, but there's no private practice, that's an opportunity for you to identify a doctor that you can possibly work with, because in some of the disadvantaged communities today, they are not private practices because communities in those areas cannot afford to pay for health services. But as soon as NHI become available, those communities, regardless of their socio-economic level, government is going to be paying through the NHI fund, who are going to be paying for those community members. So what does this say? This says to us, let's create opportunities in areas of need, particularly in rural areas, in urban communities, EKASI. Some of us come from EKAS, we can just say, okay, yeah, but so let us go back to those areas where we are coming from and create opportunities, partner with doctors, partner with other healthcare workers, and create opportunities. And of course, there are negative issues around NHI, but the positive one about, especially for us who are healthcare workers, hey, it will create opportunities for us. You will see, we will have many opportunities and we need to utilize them. Thank you.
Great, thank you so much. I'm going to end off just, Scott, your views on then furthering education, because there's usually I think it's a myth when, individuals say clinical associates are limited, and perhaps they're talking about limitation in terms of study or limitation in terms of opportunity. We've addressed the opportunity, that there's lots of opportunity, but we need to knock on doors and pave the way. What are your thoughts about then further studies? And maybe what does that look like on the African continent?
I really like what you're saying is that the doors are open for clinical associates for further study. And it's just a matter of knocking on that door and explaining who you are as a clinical associate, finding out what the requirements are, and then getting support, to make that application. And once you get that support, and I know all the heads of the divisions here are willing to write letters to the students to help with that. I mean, during my 6 years as head, I wrote many letters to other departments and other programs about what a clinical associate is, what the training is of that student, and how they are capable to be a member of your class and go through this new degree. And, in the time since I've been, as an educator, so many new programs have opened up to allow clinical associates to study. I mean, even just recently. And so we know of some of the, the big well-known universities that are coming on board and opening up these programs for clinical associates. And soon I'm going to be working with this team about collecting information of our clinical associates and where they're going for graduate studies. And so we are going to be putting out a paper that will show all the different locations where students can enter into graduate programs. And new ones are happening each year. And all it takes is students, going to those programs, starting to explain who they are, asking what their prereqs are, getting a letter of support, from educators to help with that. We've opened up whole new areas of medicine we haven't seen. We have clinical associates in transplant medicine, clinical associates in oncology medicine. Pathology is opening up to clinical associates. Home hospital care is a huge area that's opening up to clinical associates. Community medicine, as Zuki was saying, is such a big area and it's going to grow more with NHI. Clinical associates have so many education opportunities that are happening there and practice on the ground. Climate change medicine, is going to be taking on something. We hear every day in the news, about communities that are affected by climate change and how it affects the health. And we're not immune to that here in South Africa. And that's going to be an area. Occupational health. Students are studying in occupational health right now for that degree. There's so many opportunities. And I really, part of my job as an educator is to help these students enter these programs. And I'm very glad for anyone on the call, to request for a reference or to request for a letter describing clinical associates to this future program and how we could be accepted. And once the door opens up, then other universities say, we also want to take clinical associates in the program. We also want students to come and graduate, and be educated to do this. Yeah, I think this is a really big area of the future for us. Thanks, Aviwe.
Thank you, Scott. So I'm going to jump into the chat space, and this actually touches on this topic. Mutlatsi is just noting that there could be limitations in autonomy. So most organizations love clinical associates, but our autonomy is always the issue. Are there any comments? So being a supervised practitioner, as initially conceptualized, yes, the supervision sort of expands, but even at, let's say, 5 years, yes, you can work by yourself as a clinical associate. You must call your supervising doctor. But I think Mutlatsi is just talking about, where is this autonomy shaping to? But it's seen as a barrier for some of the organizations.
Suddenly you came on first, so I'm assuming you have an answer ready. So I'm going to defer to you.
Okay. Yeah. So I think this is a very important one, and there are two ways of dealing with it. One is, of course, going back to the scope of practice, and I think that process we've been trying to go with that, to say that after some years, maybe up to 5 years or less than that, there need to be some level of autonomy that a clinical associate should enjoy, because then they would have had experience. Of course, then we need to make sure that they would have been exposed to different levels of the health system, so that you don't just do VMMC for 5 years, then you say now you want to go and work in OPD. So we need to structure it correctly. But also, there is an opportunity to look into the postgraduate qualifications and say that even if I have been a clinical associate for 2 years, but once I go and I do, for an example, emergency medicine, then that should give me some level of independence to say that, because I've now specialized, I've spent two more years or 3 more years, whatever number of years that one would have spent, then that needs to give you that. And I think in our arguments, I think we need to sound reasonable to those, because these, remember, we're not existing in vacuum. There are other opposing forces, and we need to be very careful, and we need to have a strong argument. So we're not just coming here and saying, just allow us to be independent as soon as we go. We're being reasonable. We're saying, let's increase the program to 4 years. Let's look at possibilities of internship or community service, and then also look into the possibilities of postgraduate qualifications, giving you that. I think with all those, it should be possible for us to have a clinical associate who can practice without having to run after other colleagues. And I think it's also not good for those colleagues, because having someone to always run after you, hey, you can't enjoy being at work, because now every time you go that side, now they're looking for it's not good. Thanks.
Thank you, Zuki.
I want to dare add something here, which is to say, especially those that end up working in the private sector, I think it is also about creating, because you're working with just one person, it's about negotiating what your level of autonomy can be. And remember, the scope of practice does say anyway that after 5 years, it's about your supervisor being available to you. They don't physically have to be in the same space as you, but they must be available to you should you need them. Right? So it's really about what does that mean? And I think that has always been sort of kind of the discussion in the HPCSA as to what exactly do we mean by supervision. And also within the HPCSA itself, remember there's other professions that have to be supervised. And the HPCSA consistently struggles with what does supervision mean? So for those, some of us need to be able to create that space and negotiate. And maybe that is actually something, if we go 4 years, we can have a module that is about professionalism, which teaches our young clinical associate students how to negotiate that relationship between themselves and the person that they're going to be working with. So there's a lot of possibilities, and I think we're raising some good questions that we really need to, probably go home and really think about, so that we make sure that as we path the way forward, we're doing it in a responsible manner, but we are still creating, safe practitioners, and we're not just being careless in the way that we're producing them.
There is a question in the chat space from Musa, which says, as you've shared the historical background of CAs, a question comes to mind. If the goal was for us to become hospitalists while family physicians conducted outreach, why didn't the Department of Health increase the number of general practitioners working at the district level? It seems to me that this would have resolved much of the gray area our profession has been facing.
Okay, so that's a simple one. At the time, remember I'm talking history. At the time, family physicians were really trying to create or to be seen as a specialist, just like ops and gynae were, just etc. So in them creating their work, their role within the healthcare system, they decided district medicine is what we needed to do, right? And think about this, Musa. Training a clinical associate is a 3-year thing. GP is 6 years. with that, the GP, remember, one of the things that we were worried about was the fact that some of them would leave the country, but also GPs can consider specializing. So they were looking for a profession that would sort of be the backbone of the district healthcare system. And that's where the clinical associate actually came to be.
Thank you. Thank you, Zuki. And it makes sense to me. In my head, I see that. I think we still there. We haven't lost that philosophy. That still needs to happen. There's a question from Daniela.
Good evening, colleagues. Thank you so much for the engagement so far. So I'm just going to piggyback on the autonomy discussion by first making a comment to say that I think as a profession, whilst we advocate for autonomy, one of the things is that are we advocating it within the framework of making sure that we're putting the patient first? Because I think there's a lot of ego in the healthcare fraternity, and that when one's autonomy is taken away, one feels that the competency is put into question. And I say that because today I had to introduce registrars into their training platform, and unfortunately their training platform is happening within a hospital that has a lot of fellows, and it's very super specialized. And so where they come in without the competencies for that discipline, they feel like they're going back to be undergrads and interns, and they feel that they're already doctors. So you could see that there was a bit of discomfort in that they'd have to observe, it's like, I've already graduated, but now here I am sitting in a consultation room with the specialist and I'm observing. And no one's questioning your competency, but the moment of not having your autonomy in that moment is to understand that you are building up to that competency, that autonomy will come as you develop the competencies for that particular discipline. But it's knowing that it's not to hit your ego, but it's about protecting the public always. Although I must say that sometimes it's come across in the profession that some of the regulations that challenge our autonomy seem to have been as gatekeeping. In that, for example, the idea that we supervise practitioners, indefinitely, was that designed perhaps to gatekeep so that we don't encroach on the general practitioner's turf? In that now you have someone who has similar competencies and maybe have other skills. And in my opinion, because we train in the biopsychosocial manner, you get a holistic practitioner that is patient-centered. That may take away from people who their livelihoods, in actual fact, because GPs, charge for their services, we would have been seen possibly as a threat to that particular cadre. So I just wanted to know, was some of the regulations set with the idea of gatekeeping and protecting the market for certain practitioners?
No, I mean, the answer to what Daniela is asking is yes, there was gatekeeping. Whenever you come up with something like this and you're trying to create a new profession, you've got all these associations coming out of the woodwork. So a lot of it was a negotiation. Even the years of study, was a negotiation. Do we do 3 years? Do we do 4 years? We ultimately settled on 3 years, but it's become very obvious that 3 years is not enough, even if you don't change the content of what you're doing. Just in order to have a clinical associate who is at a mature level, in order to be able to be a safe practitioner, you need time for them to grow. So there's a lot of those things that now that you look at them, you say, okay, this is where we were. This is the reason why we did it. But if we're looking at the future, this is what we need to look at. So this whole idea of supervision also comes in there. I mean, maybe the thing is, and Scott and Sanele may need to, weigh in, is not use the word supervision. Is there another word that we can use that talks about working in a collaborative environment where, again, you're task sharing? Maybe that would get away from this whole, ego thing that that we really struggle with. I think you have to be a very confident person in oneself, not to feel less than when somebody says that you're a supervised practitioner. So maybe Scott or Sanele can actually weigh in. Thanks, Daniela, though. Your thoughts were very thought-provoking, for lack of a better word.
So the Health Professions Council and Medical Dental Board did request for a proposal and a process for how clinical associates could, in time, become independent. And as Sanelli said, not from day one of graduation, but in time due to their experience and their maturity and competence. And so Zuki and I were part of a working collaborative group that did submit a proposal for independence. And the CAN-C, the Clinical Associate National Consortium, all of us on the call here are members of and representing, has been now engaging with the Health Professions Council to look at that proposal. And it's proposed that it's a 3-year clerkship, so it would be involving similar to an internship program, plus the community service, and being a 3-year schedule of time that a graduate would enter into and work different disciplines and be competent in those different disciplines through demonstration of entrustable professional activities, demonstration through an electronic logbook, and showing that they are competent in these areas. And during those 3 years, they would be supervised as a direct and then slowly an indirect process. And so after the 3 years that they could be then granted a independence where they could then have this collaborative type of engagement with their other doctors and healthcare teams. Because to be honest, we aren't all independent. I mean, each of us at any level we're trained do work within a team and do work with others. And we need to seek out that advice and counsel of others. And that's what's really important. And we're always taught, as a patient, make sure you get a second opinion. So it's not that we want to be independent and on our own, but we want to be able to, I think, Danielle, as you said, stand there and be able to make decisions that one is competent about making. And then also arrive at a place where I'm not so confident in this decision, so I need to consult. I need to collaborate with someone. And that's the place that we are proposing that we move to for clinical associates. Yeah, Sanelli or Zuki, more for you guys?
Yeah, and I think this is also guided by the level of care where you are functioning. I think if you function at a PhD level, I think almost majority of what you are going to see there on day-to-day basis, you are almost able to take decisions on your own without having to consult, because guidelines are there to guide you throughout the process. But also the other point that I wanted to make is that this issue of supervision, unfortunately, I think we can deal with it in terms of practicing. We can have negotiations, but there are legal implications in it, because there are many of the regulations which would differentiate between an independent and a supervised practitioner, which then would limit us. For an example, when we were making a case for prescribing medication, one of the points made by those who are regulating authorized prescribers, they said that they cannot give such to a profession which is falling under a category of a supervised profession. So there are many of almost similar other regulations, which then, if we continue with this platform of not being seen as independent at some point in time, then we might be limited forever, because then we might never qualify to do some of the important work within the health system. So it does bring some very unfortunate limitations, which unfortunately also have impacts on patient outcomes.
Thank you, Sanele, and thank you to Mutlati for bringing that up. I think it is an ongoing discussion with the associations, with the academics. So you did touch on a very important note. It is 12 minutes past 7. The conversation could go on, but then we would be here until midnight. But thank you so much to the guests. I think this was great. It was insightful, it was informative. And one of the things that we want to achieve is not only a competent student, we want them to be confident, but then to becoming confident, they do need to be empowered, they do need to be inspired, and they do need the sense of community. So I really appreciate you joining us as industry leaders, as pioneers, as the godfathers of the profession. And yeah, it's much appreciated. I think more conversations are needed, more discussions are needed, like Zuki said, or was it Sanele, to be put out there. And let's continue to engage. I hope it was useful to everyone who joined today. And thank you for joining. Thank you for the comments. Thank you for the questions. But we're going to leave it right here and say good night to everybody. Have a good evening.